Welcome again everyone. My today's discussion is about necrotizing enterocolitis. NEC is the most common life-threatening emergency of the GI tract in the newborn period. The disease is characterized by various degrees of mucosal or transmural necrosis of the intestine. The incidence is inversely proportional to gestational age, with 90% occurring in premature infantes. Its overall incidence is 1 in 1,000 births, but it is as high as 20% in low birth weight infantes less than 1.5 kg. When we see the pathology and the pathogenesis of NEC, many factors contribute to the development of the pathologic findings of NEC, including mucosal ischemia and the subsequent necrosis, gas accumulation in the submucosa of the bowel wall or pneumatosis intestinalis, and the progression of the necrosis to perforation, peritonitis, sepsis, and death. The distal part of the ileum and the proximal segment of the colon are the most involved and the most frequently affected site. In fatal cases, gangrene might extend from the stomach to rectum. That is called NEC totalis or necrotizing enterocolitis totalis. Even though the pathogenesis of NEC is not completely known, 3 major risk factors have been implicated: prematurity, bacterial colonization of the gut, and formula feeding. NEC developed primarily in premature infantes with exposure to metabolic substrate in the context of immature intestinal immunity, microbial dysbiosis, and mucosal ischemia. The greatest risk factor for necrotizing enterocolitis is prematurity. Nearly 90% of all cases of necrotizing enterocolitis occur in premature infantes. Necrotizing enterocolitis rarely occurs before initiation of enteral feeding and is much less common in infants fed human milk. Aggressive enteral feeding might predispose to the development of necrotizing enterocolitis. NEC can also sometimes occur in interim babies, and in term infantes, it is often a secondary disease seen more frequently in infantes with history of perinatal asphyxia or birth asphyxia. Down syndrome, congenital heart disease, rotavirus infection, gastroschisis, and Hirschsprungus disease are also another risk factors for developing NEC in term babies. Infantes with necrotizing enterocolitis have a variety of signs and symptoms, and they may have an insidious or sudden catastrophic onset. The onset of necrotizing enterocolitis is usually in the 2nd or 3rd week of life, but can be as late as 3 months in very low birth weight infantes. The first sign of impending disease might be non-specific, including lethargy, temperature instability, abdominal distension, feeding intolerance, and bleeding stools. Because of these non-specific signs, sepsis might be suspected before necrotizing enterocolitis. The spectrum of illness is broad, ranging from mild disease with only bleed-positive stools to severe illness with bowel perforation, peritonitis, systemic inflammatory response syndrome, shock up to death. Laboratory derangements might include neutropenia, anemia, thrombocytopenia, coagulopathy, and metabolic acidosis. Hypotension and respiratory failure are also common, and it is the terminal stage of the disease. Progression might be rapid, but it is unusual for the disease to progress from mild to severe after 72 hours after the onset of symptoms. When we see the diagnosis of necrotizing enterocolitis, a very high index of suspicion in treating preterm at-risk infants is crucial, and supine abdominal X-rays are the mainstay of diagnosis, and if perforation is suspected clinically, there is a concern on supine films. An additional cross-table, lateral or left lateral decubitus view provides increased sensitivity. Findings on plain radiographs include dilated bowel loops, bowel wall edema, pneumatosis intestinalis, portal venous gas, and pneumoperitoneum, which indicates severe disease. The other investigation is ultrasound. On ultrasound, we see bowel wall thickening, alteration of the vascular state, which can be hypervascular or hypovascular, intramural gas manifesting as hyperechoic focus within the bowel wall, free fluid, especially with echogenic debris, suggesting perforation. When we see the treatment of necrotizing enterocolitis, rapid initiation of therapy is required for infantes with suspected as well as proven necrotizing enterocolitis. There is no definitive treatment for established necrotizing enterocolitis, So therapy is directed at providing supportive care and preventing further injury with stopping of oral feeding or cessation of feeding, nasogastric decompression, administration of IV fluids, careful attention to the respiratory status, coagulation profile, acid base and electrolyte balances are very important. Once blood has been drawn for culture, systemic antibiotics with broad coverage of gram-positive, gram-negative and anaerobic organisms should be started immediately. If present, umbilical catheter should be removed. And also the patient score should be monitored closely by means of frequent physical assessment, sequential AP and cross-table lateral or lateral decubitus abdominal radiographs to detect whether there is intestinal perforation or not, and serial determinations of hemoglobin, electrolyte and acid base status. Gown and glove isolation and grouping of infantis at similar increased risks should be done. When we see the place of surgical management in the case of necrotizing enterocolitis, the only absolute indication for surgery is evidence of perforation on abdominal radiographs, that is pneumoperitoneum, but this is present in less than half of infantis with perforation or necrosis at operative exploration. So, progressive clinical deterioration despite maximum medical management, a single fixed bowel loops on serial radiographs, and abdominal wall erythema are relative indications for exploratory laparotomy. Ideally, surgery should be performed after intestinal necrosis, but before perforation and the peritonitis occur. This is modified Bell's stage for necrotizing enterocolitis based on systemic findings, abdominal findings, and also radiologic findings with their treatment plan. There is around 3 stages, each have A and B. So for suspected necrotizing enterocolitis, antibiotic is given for 3 days. For definite enterocolitis or stage 2, antibiotic is given for 7 to 10 if it is mildly or A type of stage 2, and it is given for 14 days if it is B type of stage 2 or moderately ill. Regarding prognosis, medical management fails in approximately 20 to 40% of patients with pneumatosis intestinalis at diagnosis. Of this, 20 to 50% will die. Early postoperative complications include wound infection, dehiscence, and stomal problems like prolapse and necrosis. Later complications include intestinal strictures, which can occur in approximately 10% of medically or surgically managed necrotizing enterocolitis. Short bowel syndrome can also occur after massive intestinal resection, which can cause malabsorption, growth failure, and malnutrition. And also complication related to central venous catheter such as sepsis and thrombosis, and also cholestatic jaundice can appear. When we see the prevention of necrotizing enterocolitis, the most effective preventive strategy for necrotizing enterocolitis is the use of human milk. Regarding the use of probiotics to prevent NEC, there is no clear consensus on the safest, most effective formulation, timing of administration, or length of therapy. So it is currently on under study. It's not effective as such. Inhibitors of gastric acid excretion, such as H2 receptor blocker and the proton pump inhibitor, or prolonged empirical antibiotics in the early neonatal period, have been associated with increased risk of necrotizing enterocolitis. So those things should be avoided. Early detection and the treatment prevents late deleterious consequence of necrotizing enterocolitis. So always keep in mind while taking care of preterm or premature baby. This is all about what I have regarding necrotizing enterocolitis. Have a nice day.